So Matt and Kristen and I, and Renato decided that we would have the fellows present their research each year. And we've had a couple of fellows when they're kind of a graduating fellow. And we had a couple of fellows do that this year, and we will make a decision about expansion or mandatory, all that kind of good stuff as we move forward. But Lauren, I think, is the third DCRI fellow to do that during this academic year. And three people will be presenting today. Mickey Cohen-Wolkowiez, who was a fellow last year, who joined us on faculty just a few months ago. And I'll give 6 or 7 slides, and then Lauren will speak. Lauren is a critical care fellow over at Duke, and then she's going down to Carolinas Medical Center to their critical care nursery down there, and is going to extend some of our work with ECMO, PK, and children down there. So with that, I'll just I thought about having this as the title for the whole presentation, and then I thought that's a little aggressive for a third-year fellow to say. So this is a maybe not so famous quote from a 16th century physician. All drugs are poisons. The benefits depend on the dose. And, all drugs are toxin. In some patients, the correct dose given to this right group of patients is occasionally a therapeutic. I just want to give you a few background slides on why we decided to move in this direction as a research group. This is a picture of the back of a baby. This baby was 24 weeks gestation, born at 650 grams. So that's about a pound. The baby developed this lesion while on liposomal amphotericin B and on caspofungin, and it then expanded while it was on voriconazole. And the team had adult appropriate dosing for those agents in this baby, and things were getting worse. It had grown from about this size lesion here to covering the entire back. And they called me up at we had a conference call one night, and we had been working in the lab on an antifungal in bunny model, and we were realizing that we actually needed dosages 3 to 4 times what the adults needed, and with some of these agents. So I showed him this data over the phone. God bless you, Doc. I showed him this data over the phone, and this is a log of invasive fungal infection on this side, and this is the dosage here. And adults get about 2 milligrams per kilogram, and they get a very rapid drop, and the curve's like this. But in the non-neutropenic bunny model, we were seeing that the bunnies needed about 15 per kilo, and that equates to about 12 per kilo, 10 to 12 per kilo in a premature baby. And the non-neutropenic bunny in therapeutics past had really predicted well whether or not you could transfer into adult dosing into babies. So I said, increase your dosing from 2 mg per kg to 10 milligrams per kilogram, and you're going to try and get an AUC of about 200, 250, and you need to move your dosage of voriconazole up from about 2 mg per kg to about 10 mg per kg as well. They thought that I was nuts, but they did. They moved the mycofungin dosing up to 10 per kilo, and this was the baby right here about 2 or 3 weeks after we changed therapy, and then this is the baby right before transitioning to car seat. This baby, you don't walk out of the hospital, right, if you're a baby. Like, this medical intensive care unit patient walked out of the hospital. But the babies, they go to car seat out of hospital. This baby went to the car seat out of the hospital. And as we predicted, the voriconazole dosing levels were extremely low, and the therapeutic was right where we targeted it. And at this point, Brian and Mickey and I were kind of sitting around, what are we going to do as a research group? And we started looking up therapeutics that are licensed, that have been licensed for decades, that have been shown to be safe and effective in adults, and to see how much they've been studied in children. Now, the 400,000 babies that are admitted to an intensive care nursery in the United States every year, it's about 400,000, 90-some-odd% of them will receive ampicillin. The number of babies less than 28 weeks who've ever been studied in any kind of PK dose for a product given to hundreds of thousands of babies every year for the past couple of decades and for the foreseeable future, 6 babies, 6 to 28 weeks of age, and none in babies less than 26 weeks of age. If you take the rank order list of therapeutics, ampicillin is the most commonly used therapeutic in the nursery, and you rank them from 1 to a couple hundred, you can see these are the antimicrobial agents. The picture's the same for non-antimicrobial agents. These are the number of babies less than 28 weeks gestational age that the therapeutics have ever been studied for any kind of PK data. So we decided as a research group we wanted to change that. And so we decided if you're going to be really good at something, you want to go into an area where there's not much competition. Therefore, it's pretty easy to look good. So we actually did the studies on mycofungin. We showed that you really want to give about 10 milligrams per kilogram for the target AUC. That was in a series of publications that Brian and Mickey and I did. And then we, as a group, decided that we were going to expand our horizons across from antifungals in the nursery to all therapeutics in the nursery, and upward and downward in age to older children and younger children. And so that we then have since through the DCRI, we have about 15 ongoing or completed trials where we either we hold the IND, occasionally the sponsor holds the IND, and most of these are run out of here. That is more antimicrobial studies in premature babies for off-patent therapeutics than all other research groups, drug companies, and government agencies in the world combined. So if you're ever wondering, like, where does my overhead go? We're a slightly money. We don't lose much money, but we do lose a little bit of money, and so that's some of where your overhead goes. I thank you for that. Lauren is going to present on one of those studies, which is the fluconazole loading dose study, and Mickey, go ahead if you want, Lauren. And Mickey is going to then present on some general principles about loading up information into PK trials and modeling and he's promised me that it'll be something that the clinician and maybe those of us without quite so much PK expertise will feel comfortable listening to.
Yes, okay, sorry. I'll speak louder. My name's Lauren Piper, and as Danny said, I'm in critical care in pediatrics. And my fellowship research project was looking at a fluconazole loading dose in infants that are critically ill, was the majority of the population. To give you a little background of what a big problem this is, candidiasis is a leading cause of morbidity and mortality. It actually is the 4th leading cause of hospital-acquired bloodstream infection. What we do know about it is that prompt therapy overall is going to improve outcomes. But despite prompt therapy, still about 20 to 30% of infants will die. And you're probably wondering how big of a problem this is at Duke, at least in the PICU that I work in. This is data from the past 3.5 years. And surprisingly, actually, Canada is tied with coag-negative staph as the #1 cause of bloodstream infection. So it's an even bigger deal at our institution. So fluconazole is a drug that is usually the first line of therapy and is often started empirically in the setting of thrombocytopenia or depending on their critical illness. And one reason for that is that it has excellent activity against Candida species, particularly the ones that we see most commonly, Candida albicans and parapsilosis. Another reason that we use it, besides its broad Candida activity, is because it has a favorable PK profile. It has a very long half-life, so can usually be dosed once daily. It's renally excreted. And then lastly, one very important consideration is that it has excellent CSF penetration, which is particularly important in infants that would be at risk for developing meningitis. And then lastly, overall, in comparison to other antifungals, it's very well tolerated, particularly the older ones. So the adults actually have been using a loading dose for a long time, and you're probably wondering why aren't we doing that in pediatrics, but you saw, as Danny alluded to, the lack of PK data in infants is really the reason why we're not doing it. But the adults do this, they use a loading dose to be able to achieve the therapeutic target by the second day of therapy. And what we know from some data that Kelly Wade and Danny had done is that the current dosing that we're using right now, or just recently in the ICU at Duke, takes 3 to 5 days before it even reaches the target concentration, and takes 5 to 7 days before it reaches the steady state of this. There's simulation PK studies suggest that a loading dose is also needed. And in this graph, you see along the y-axis is the fluconazole AUC. The goal that we use is a goal of 400. And along the y-axis, you see right there, is the number of days of therapy, with the target range really being between the two blue lines. And this is the current dosing of 12 per kilo, and so it's going to take almost a week before it reaches steady state to reach the AUC. And then a loading dose of 25 per kilo in the simulation study was showed that the target AUC could be reached after the first day of therapy. So the objective and hypothesis of the study was to determine the PK and safety of a fluconazole loading dose in infants that were at risk for invasive fungal infection. And the hypothesis was that it would safely achieve the target AUC of 400 after the first 24 hours of therapy. The primary outcome was just the number of infants that would be able to achieve this goal after 24 hours. And some of the other secondary outcomes that we looked at, the biggest concern was for liver toxicity, so whether or not these infants developed an elevation of the AST or ALT. And then lastly, looking at the volume of distribution and the fluconazole clearance versus creatinine. For the study design, we looked at infants and toddlers that were less than 2 years of age, which certainly is probably the most common population to receive fluconazole in this setting. And all the infants received a loading dose of 25 milligrams per kilo, so basically double the standard dose. And then they received the standard dose of 12 milligrams per kilo for additional 4 days. The PK sampling that we did was we did 4 samples that were throughout the first 24 hours of therapy, and then we looked at samples before and after the 3rd dose and the 5th dose. We were able to minimize blood loss. Infants lost less than 800 microliters, so very small amount of blood. And then we did, for safety reasons, checked the pre and post liver enzymes, and then, of course, monitored for adverse events for 7 days. In addition to the age criteria for the inclusion criteria, they had to have be suspected of a systemic infection and had to have a recent blood culture. They were excluded if they had recent fluconazole exposure in the past 5 days. This was so that it would not interfere with the PK assay. They obviously couldn't already have liver dysfunction, and they also couldn't have renal failure, which we define as a creatinine greater than 1.3. And they could not be on cyclosporin or tacrolimus or azithromycin. For the cyclosporin and tacrolimus interferes with the P450 and could cause trouble that way. And then lastly, any allergy to any azole. For the PK analysis that was done by Mickey, we used a validated bioanalytical PK assay that was performed at CHOP. And then we used, which Mickey's going to talk more about PK modeling, we used the one compartmental model, which is a simulation model based on the real PK data to estimate the PK parameters that we were looking at. And then we calculated the AUC after 24 hours using the trapezoidal rule. In terms of our results, we had 12 infants that were of mostly term gestation, the youngest being 24 weeks, the median gestational age was 37 weeks, and almost half were male, and nearly 2/3 were black infants. And to give you an idea of, this next table gives you an idea of how sick these patients were. These are very, very ill patients. Over 90% were in the ICU. At Duke, as you know, that there's a large cardiac ICU where actually 3/4 of the patients were enrolled from. Almost, or 83% of these infants were on mechanical ventilation, and 1/3 were on high-frequency ventilation. So very critically ill infants. We also had one infant that was on ECMO, or like a bypass support. And then there were 3/4 of the infants that had congenital heart disease. In this next table, along the y-axis, you see the fluconazole AUC. Again, the blue line is marking an AUC of 400, which is our target. And then along the x-axis is the number of subjects. Overall, 72%, so 8 of the 11 infants that received a loading dose achieved the target AUC. And then there are 3 that did not. Of the 3 that did not achieve the target AUC, there was one of these infants was on ECMO. The mean AUC was 463 for these infants, with the interquartile range being 377 to 506. So most infants got very close to the 400 goal. The volume of this distribution was quite variable, which probably accounts for the critically ill patients, along with the clearance. This next figure shows the predicted fluconazole concentration over time. This was done so that you could compare the exact, if an infant had a PK sample done at 20 hours and another one at 3 hours, or 24 hours, we did a simulation model so that you could compare the exact time at 24 hours, 48 hours, and 72 hours. And the purpose of this was just to look and see. You can't really claim that steady state was achieved, but there was very little accumulation. It was probably nearly achieved after the first 24 hours. This next figure is the fluconazole clearance versus the serum creatinine, which is a regression line. And you can see that obviously the fluconazole clearance decreases with increasing creatinine. There are a few outliers, one of which was a child that was on ECMO. In terms of the safety and the adverse events, there were 0 that were related to the study drug. We did not see any change or even elevation in AST or ALT. There were 2 likely unrelated adverse events. There was one event of ventricular tachycardia. This was in an infant that had a known history of this, and this was after 24 hours of receiving the loading dose. And another infant that had worsening renal insufficiency that was on ECMO that had that already had that pre-existing. So in conclusion, the loading dose of 25 milligrams per kilo achieved the therapeutic target AUC of 400 in 72% of the patients, so 8 of 11. Overall, it was very safe and it was well tolerated. And so we believe that empirical and treatment courses of fluconazole should include a loading dose of 25 milligrams per kilo at the beginning of therapy. So in discussion, this is the first evaluation of a loading dose in infants. It's certainly very understudied in this population. And the strengths include really a very critically ill patient population that would be similar to the patients that would be receiving this on a day-to-day basis. We're able to get frequent PK samplings within the first 24 hours after the loading dose to better characterize the PK. And then, as you saw, there was one of the 3 patients that were on ECMO that was subtherapeutic, and that's certainly that we've seen another patient in the nidulefungin study that was the case, and it's definitely an area that we're going to further explore in the future, not knowing whether or not all the patients that are on ECMO that are on antibiotics, if those are even remotely therapeutic. The limitations, certainly, as you saw, that 3/4 of the patient were in the cardiac ICU, many of which had single ventricle physiology, and whether or not this population really is generalizable. Many of them had very changing clearance, which fluconazole was renally excreted. And then lastly, some of the patients were just even too ill to be weighed if they were on high-frequency ventilation or ECMO. Their weights may not have been entirely accurate, which could have affected the results as well. So in the future, besides looking at the PK of fluconazole and other antimicrobials on ECMO, we're also going to be looking at the loading dose in preterm infants that are less than 30 weeks, so the 24 to 30 week infants. And then we're also going to look at more infants that are kind of more your older infants that are between the ages of 2 months and 2 years. And lastly, I just wanted to acknowledge my research mentor, Danny and Mickey and Brian, and the staff from the PICU along with the DCRI. Thank you. I think next, Mickey is Cohen-Wolkowiez is going to talk about the impact of PK/PD modeling.
I think we'll ask questions at the end.
Can you hear me okay?
Sounds good.
All right. So I think that Lauren's talk is going to be very useful for me because she already touched upon several concepts that I'm just going to highlight in my presentation because her study is pretty much an application of what I'm going to talk about now. And even though the title of the talk is Neonatal Drug Trials Impact of PK/PD Modeling, what I'm going to concentrate on is on actual sample times and why that is so important in pediatrics in terms of the number of samples that we collect for a PK trial and then when we collect those samples. And as Danny said before, I promise there's not one single equation in my presentation. So, Danny already alluded to this, but as he said, there aren't a lot of studies that have been done in neonates in terms of antimicrobials and other drugs. And it's the old paradigm where we take a drug and it's used in adults, we divide it by 70 kilograms, and then we take that and give it to all the babies. We find out that it really doesn't work because we've seen a lot of surprises. And this table just shows you for several antimicrobials what's the preferred adult dosing per kilogram of body weight, and this is assuming an average weight of 70 kilograms. And then so far, what's the information that we have in terms of dosing in infants? And you can see that there are quite a big difference. Some medications here are actually required higher doses in infants than adults, when you would think that because of size they would need decreased amounts. And this is just one slide on a reminder of what are the therapeutic targets when we're talking about antimicrobials. And you have here a graph that depicts the concentration of the drug on the y-axis and then time on the x-axis. And what we're trying to figure out is how do antimicrobials work? And it depends on the type of antimicrobial. Some of them work by achieving a very high peak. And that will be, for example, aminoglycosides, where you can just dose once a day. And what you're interested in, your goal is to try to describe this peak here because that's going to be associated with success. There are other drugs like penicillin that work in terms of the amount of time that they're over a certain concentration. And that's certainly a different type of target, because then you're looking about the time over the minimum inhibitory concentration for a particular organism. So for example, if you're dosing the medication every 8 hours, you want to make sure that you're over that minimum inhibitory concentration for 50% of the time, so 4 hours or 6 hours of that dosing interval. And these concepts are important because that's how you're going to define your target. Now, antifungals is a combination of both in terms of how they kill, and they are defined by the area under the curve. So what we do is that we get this profile, we're able to calculate the area under this curve, and that number is associated with efficacy. So what is PK/PD modeling? It's the use of mathematical and statistical tools to describe or predict the PK and PD process. And there are certainly different modeling stages, and these can be used before study startup. And this is one of the most important uses that we have for it in pediatrics, because we want to make sure that we have an appropriate study design before we enroll the babies in the study. And then you can certainly use it after the study is completed to do the analysis like Lauren did and give you the results and then analyze the information. Now, when we use it for before we start the study, it's very important to figure out two things. What are the sampling times that we're going to use? Are we going to use 2 samples, 4 samples, 10 samples, 12 samples? And when are we going to collect them? Because these samples in pediatrics are very precious for us, because we can't get a lot of samples like adults. So therefore, it's very important to plan ahead of time, and I'll show you an example as to why that's so important. And then what's the appropriate dose? Can we just take the adult dose? Do we need to figure out a different type of dosing that's going to achieve the same target? So this is, when I'm talking about sampling times, this will be a typical profile of concentration time profile of an adult, where you're giving the drug here at time 0, and then you're collecting samples over time. And this is an adult where we collected 12 samples. And if you wanted to take the AUC of that, then you just calculate that area, which is depicted here by the green area. Now, if you take that information and you want to do that study in infants, you have several options. So you can take 4 samples and add the appropriate time points. And you can see here that the green area is pretty close to the adult area, even though you're only using 4 samples instead of 12. But if you don't plan ahead, you may decide that you want to take a different sampling strategy, taking the same number of samples but at different time points. Now, this area is probably overestimating the adult area. And then the other scenario, you may decide, well, I'm just going to take 2 samples, one at the beginning, one at the end, and that's going to be it. But really, this is not going to do an appropriate estimation of the area under the curve. So this is where it becomes key to define before you start the study how many samples and where you're going to take your samples. Now I'm going to go through a real-life example of a drug that we studied, where we went through the whole process of doing the study design using modeling, trying to determine what are the best sampling times, the best dose, and what are the results of that. And the drug is named Acknowledgements. It's an intravenous echinocandin antifungal, just like fluconazole, but in a separate class. The elimination of the drug is by chemical degradation in the blood, and that's a key factor when you're trying to analyze your drug in pediatrics, because if the drug is renally excreted, like penicillins, or if the drug is metabolized by the liver, pediatrics is a moving target. So it's very important, if you have those mechanisms, that you analyze what's the renal function in a 1-month-old, in a 5-month-old, or in a 1-year-old. And the same applies for the metabolizing enzymes in the liver. How developed are they in the first month of life, for example? In this particular case, we didn't have to worry a lot about that because the drug just degrades in the blood. The killing mechanism that has been established for this drug is the AUC, as I showed you earlier. And we had a target AUC of 100, which has been shown to work in older children and adults. And this AUC in adults was achieved with a 3 milligram per kilogram loading dose, followed by a 1.5 milligram per kilogram maintenance dose. Now, this is the clearest information that we have from adults. You can see the mean here and the standard deviation. And the first thing that pops up is that the difference in standard deviation between children and adults. And that's because typically these studies in adults are done in normal volunteers. So you expect that normal volunteers are similar to each other. And in children, we usually use sick population. And in sick population, you expect that the variability is going to be higher. Now, in order for us to design this study, we have to pick out what are the best sampling times. And there are different ways of doing it, but just the big picture is that you want to pick up samples where you're going to get the most information dependent on your target. For this particular drug, we wanted to describe AUC, and therefore you can think like getting a peak and a trough would be important because that will give you both ends of the spectrum in terms of the AUC. And then these 2 points in the middle here are key because they're going to describe what are the areas where the biggest change is occurring, and that's what you want to capture. There are software that can do that automatically, but what you want to try to do is pick the time points that's going to give you the most information. So that allowed us to go from 12 samples to 4 samples per patient. This is the data of the first 7 patients that were enrolled in the study, and you can see here that the sampling times is similar to what we had planned at the beginning of the study, but there are some patients that didn't quite follow that. And again, it's because we're dealing with premature infants where maybe the sampling time that we had planned in the beginning, we weren't able to take it because the patient was critically ill, etc. So it matches what we planned in the design, but not 100%. And you can see that the variability here. So this is a patient, for example, that if you calculate that AUC had an AUC of 30, and remember that our target was 100, and this is another patient where the AUC was 113. And again, going back to the question that these patients are sick. But if you look at the overall population and you look at the median AUC, it's 92. When you compare it to our estimate, or what we wanted to achieve was 100, you could consider this a successful trial. And this wasn't because we are particularly smart. It was just because we actually planned ahead, and we collected the information that we needed to achieve this goal. Now, the importance about PK/PD modeling is taking that information, and the whole point is that you want to predict. So you want to make sure that you can apply it to your patient population. So we have an average patient here, and I chose a hem-onc patient where we did the dose simulation to see what would be the dose that we would need to achieve the target of AUC of 100. And in this particular patient where we don't necessarily want to treat a central nervous system infection, when we're not thinking that they are on ECMO, they're hem-onc patients, but they're not that ill, and then you can go with the average clearance, and the average dose is going to achieve an AUC of 100. Now, if you're thinking about a special population, like Lauren was alluding to earlier, on ECMO, for that you have to make several adjustments because typically patients on ECMO, so you have the patient and then you have the bypass machine. So you can think about a volume of distribution for the patient, and in addition to that, all the blood volume that goes into the machine, and therefore your drug is being diluted now into 2 systems. And the patient that I showed you that had an AUC of 30 was a patient that was on ECMO. So in this scenario, and then you have the clearance of the baby. So it degrades in the blood of the baby, and then it degrades in the machine. It gets stuck to the circuit, and then it gets stuck to the oxygenator. So there's a lot of things that go on in this machine that we don't know about, but we have to try to plan in advance and see how we can dose these patients. So in this particular scenario, this patient had the highest clearance. So in order to reach an AUC of 90, we would have to give him a loading dose of 9 milligrams per kilogram and a maintenance dose of 4.5, which is 3 times the dose that we would give the hem-onc patient. And maybe because they have such a high clearance, you don't even need to give a loading dose. Maybe if you just give 4.5, you're at steady state from the beginning. And then the other population that we're very interested in is in babies with candidiasis. And we know that babies with candidiasis not only have it in their blood, but they also have it in the CNS. So in that particular scenario, and assuming a 20% penetration into the CNS, and that can come from animal models, if we wanted to achieve an AUC of about 90 or 100 in the CNS, we would have to give 12 milligrams per kilogram and 6 milligrams per kilogram maintenance. And then, we can continue to go up. Let's give 20 milligrams per kilogram, but we don't know where our efficacy starts and then our safety ends. And therefore, this approach would be great, but again, this hasn't been studied, and we don't know if this is going to be safe in this population. So in summary, PK/PD modeling is a useful tool for study design in terms of certainly sampling times and dosing. Obviously, it serves a purpose in analyzing the results, and then taking that information and using it to predict for particular patient populations, which is what we're most interested in. And certainly in industry and in regulatory agencies, PK/PD modeling is being used across the board in pediatric trials. This is my acknowledgement slide for the research team here at Duke, and I'm also enrolled in a PhD program at UNC in pharmacotherapy, and those are my advisors from UNC. I'm done.
Thanks. Can you turn off that? Is it this one, Charles? Oh, thanks, Charles. With that, I'll open it up for questions. I have two, one for each of you guys. One is for Lauren, which is why the AUC of 400 for fluconazole, and what kind of data that's based on. Because remember, we have people who've not necessarily done the adult studies. And then for Mickey, if you could think about physiologic differences for two populations that I think regulations, they're not coming this year. They're not going to come next year, but they'll come before I retire, which is the elderly, actually doing these studies in the elderly, and in pregnant women, which during my career, I think we'll see the agency require those studies specifically, just like they've required them in children. And if you could talk about the physiology and because we have a known missing, right? We have a known wrongness rate of about 40% in children. So if you could speculate on that, that'd be great.
I guess this is working. So the AUC of 400 is the target that we're using in children, and that's based on both in vivo and in vitro data, and that's to get you up to an AUC to MIC ratio greater than 50 and 90% of infants. However, I will say that in adults recently, if you're critically ill, they've started to use a higher AUC of 800, in which, if you remember on my slides, none of the, only about 70% of the babies were reaching the 400, which is kind of the lower target, and none of them even came close to reaching the 800 is where those targets are coming from and possibly changing, at least in the critically ill population.
This is working. So I think when we deal with pediatrics and we're used to trying to figure out the best way of making these studies work, the questions about elderly and pregnant women comes up all the time, because starting with the elderly, you can picture them as in the same, they're both at the end of the spectrum in terms of age. So therefore, we have an older population now, and as we don't know a lot of the PK in pediatrics, and we don't know a lot of the PK in the elderly. And one of the big problems with the elderly is that there's a lot of polypharmacy. So drug interactions in the elderly and how their renal function changes over time is not very well described, not until the ages that where patients are surviving now. And there's also a population that's taking drugs that we weren't expecting. So, for example, elderly patients that are taking HIV drugs. In the 80s, we didn't think that they were going to survive that long, and now they are. So in addition to HIV drugs, now they're taking antihypertensives, and they're taking medicines for diabetes. So concomitant medications in that population is going to become a big deal. And if we don't study those, then we're not going to pretty much know what the PK is of these drugs in that population. And then pregnant women, that's like a completely, that's like the twilight zone. Because in the sense that who is going to participate in a study, you're pregnant and you don't know what the safety of the products are in pregnancy. So how are you going to recruit those patients to participate? But on the other hand, we give them the drugs anyway. And the best examples is anti-seizure drugs. So pregnant women, when they have a seizure disorder before getting pregnant, they continue to have seizures when they're pregnant. But we don't know how these drugs work when they're pregnant and how much dosing we need to give them. Antidepressants is a very common example. So women that are taking antidepressants before, during, and even after pregnancy, we don't know the PK of that at all. And a lot of the antidepressants don't work in normal people. You can imagine if you're not giving the appropriate dose to a pregnant woman, how is that going to work in a pregnant woman? So I think that what the approach that we're going to start seeing, and in terms of physiologic differences, certainly you have to think, I think the most important thing will be volume of distribution, just because, again, they have another human in there, so you have to account for that. And that means that pregnant women may actually need higher doses than non-pregnant women. But how are we going to study them? It's probably through standard of care. So if pregnant women are taking antidepressants or they are taking anti-epileptic drugs and they're getting samples collected, we can just start with those that are going to get the drug anyway, but at least we can study the PK when they're taking it. So I'm not sure if that fully answers the questions, but just a few examples of how we're viewing that and how important that's going to be for the future.
Charles, can you get the two gentlemen in the back? And then we'll get Judy.
Yeah, I just have a quick question. Why do you see a greater decrease in concentration over time with a higher loading dose than you do with a lower loading dose?
A higher decrease in concentration over time? Did you see that in one of the slides?
Yeah, it was in one of the earlier slides.
So typically with a higher loading dose, you should achieve concentrations that are much higher than the maintenance dose. You just achieve the concentrations earlier. So if you give, is that the question? Or?
I bet you it's related to the steady state slide. No, then I guess wrong. Okay.
Yeah, so that.
Yeah, so where you have a higher loading dose initially. Where you have a higher loading dose initially, you see a greater drop in concentration over time than you do with a lower loading dose.
No, so these are actually patients that receive the same dose. I'm sorry if I wasn't clear. So these are the first 7 patients. They all got a 3 milligram per kilogram dose and then a 1.5 maintenance. And these are samples that are taken around a maintenance dose. So the variability here in terms of the curves are related to the fact that they are very different patients. So one was an ECMO versus another one that wasn't. But in general, in terms of PK, what happens with the loading dose should happen with the maintenance dose. A dose that precedes another dose shouldn't affect the PK. In general terms, there are cases where that doesn't apply, but in general terms, one dose should not affect the next.
Yeah, I think that's a really good question in that you look at some of the PK data from, healthy adults, and they're all going to be clustered around this pink line, right? But you start going into children, and you get some crazy enough variability that the curves are so different, it looks like the only explanation can be that they got a different dosage. But all these patients got the same dosage. It's just that your variability is all over the place, okay? And so what you read in a textbook is X per kilo because they're taking the median line here. But as a clinician, you got to worry about this baby too.
And that's another thing that has, I think, set us apart from other research teams. Is just that typically you want to reduce your patients to something that you can control, so where your variability is not going to be that high. So patients on ECMO will probably be excluded from this study because obviously we know that they're going to be very, very different. That's not going to be generalizable. But on the other hand, if you exclude them, you're never going to study these drugs in that population. So we want to make it as inclusive as possible, expecting that we're going to see that variability, expecting that the ECMO patient is not going to be your average patient, but at least we know what the PK is in those patients. And you had a question?
Excuse me. My question's in follow-up to your comments on adults. So that's where the kind of people we take care of. In adults, I think unlike children, we have to worry about distribution into fat and muscle. So water and hydrophilic and lipophilic drugs and where they're going to distribute. And I'm curious, so as people age, that distribution changes, and I'm curious how that would get pretty complex in your modeling. So I'm curious how most of our drugs that we look at, some of our antithrombotic therapies, we do dose adjust based on BMI, but many of them we don't. And certainly we generally don't, except for potentially with things like Ativan, et cetera. We don't think about their accumulation in fat. And that's not even formally. That's if somebody doesn't wake up after they've been intubated, we say, we kind of wave our hands and say, well, they've got a big, it goes into their fat store, and this is a big lady, so maybe it'll take her longer to wake up. So I'm curious, how do you put that into your model, and do you account for it in children? And if you were to expand into adults, how would you model that?
So at this point, we are aware that changes in children in terms of your adipose tissue distribution since birth and throughout the first year of life. Just like your renal function changes and your water content changes, your adipose tissue distribution changes as well. But we are not incorporating that into our analysis as of yet, and that's going to be very drug dependent. So a very hydrophilic drug, you're not going to think about it that much because it's not really going to get into adipose tissue. But if you have lipophilic drugs, then you are. Now, when you're trying to do modeling and trying to do a mechanistic approach, meaning you want to describe every phase of where the drug is going, then you start getting into the problem of getting the samples, because you need not only what happens in the blood, but you need what happens in the tissue. And the way we get help with that is animal models, where you just kill them and you get the tissue. So it's easy for them, but we obviously can't do that in neonates or humans. So since we have the limitation of the number of samples that we can get and the compartments that we have access to, I see that more of a theoretical question that may be answered more through modeling. So if we know what the like the log P is of the drug into the fat tissue from animal models or maybe from adults, maybe we can take that into account as a fixed parameter, not having to estimate it, and then maybe see what kind of differences we get. But certainly it makes the modeling much more complicated once you start doing mechanistic work that is done in animals and adults, but not so much in children.
So before I get to Judy's question, the follow-up to that, Matt, is this is why I speculate that you guys are going to face having to study these drugs in the elderly 5 or 10 or however many years down the road, because eventually the average age of Congress is going to exceed 80 or 112 or whatever it is now, and they're going to realize, gee, we've been getting all these PK data from 25-year-old Caucasians who have had about 7 years of college, whether or not they have a degree, and they go down to the healthy volunteer PK station for a feed and bleed study, and then we move that into 80 and 90-year-old humans who have a much different physiology. And you guys might not be as wrong as frequently as we are, but I bet you're wrong more often than you think you're wrong.
Yeah. And you know, you may not necessarily describe why those differences are, but you'll be able to say that they exist. So you may not be able to say, oh, it is because the drug is going to the fat, or it's not going there, or some other type of covariate. But you at least are going to be able to say with a sort of simplistic approach, yes, their PK is certainly different. They need a different dose.
First of all, I want to congratulate your whole team, because this line of research is so important. The very weird thing, I have to say it right up front, the very weird thing for me is that in my early career at UNC, 38 years ago, we were doing the first gentamicin kinetics and trying to convince the clinicians that they should change the way they were dosing gentamicin. I then did my internship at Mass General, and it was like going into the dark ages, because at Mass General they did no pharmacokinetics. They just dosed everybody, and there was a lawsuit over a homeless person who was treated with an empirical dose of gentamicin and had vestibular problems ongoing after he recovered. Anyway, what I'm going to ask a slightly different question. I'm really interested, back in those days, and for many years, most of this research was done by pharmacy-type people in pharmaceutics departments, and there was not a lot of interest on the clinical side. And we know where Danny got his initial interest, I presume, doing the study of the gaps in pediatric research by looking at the FDA database. But I'm really interested in asking you, Mickey, you're getting a PhD in pharmaceutics and you're a physician, the order of how this worked for you in terms of your career influence. Did you start in medicine and then just kind of get this interest and decide to go into that, or did you start in pharmaceutics and then decide to go into medicine? I'm just very curious about the natural history of how we get clinicians thinking about these important areas and doing research in these areas.
So I started in medicine, and I never thought that I was going to end up here. And when I actually came here for my fellowship, before, when I met Danny during interview process, we started talking about therapeutics, and that just got me started thinking. And then when I came here, as fellows during our first year, we were pretty much it in terms of the service, and I realized even more how little information we had on therapeutics. And then after that, I started with the Anidula fungin project that I presented the data on, and then one thing led to another, and I enrolled in everything happened real quick, and then I enrolled in a PhD program, and I went to several meetings nationally where I saw that there's probably 5 pediatric pharmacologists in the country that do this kind of work, and certainly something that I was very interested in through the research that I was doing. So it just made sense that, if there's only 5 people, I'm sure that that's probably going to be a good thing for me to be the 6th. So that's how it kind of started, and then I got involved with the FDA as well, and I've been there for almost a year, like a scientific advisor to the Office of Pediatric Therapeutics. And that, again, is something that Danny and Brian did as well, and that just complements not only the research experience here, the PhD at UNC, but also the regulatory side of things, which is a whole different ballgame. And I have to say that in the past 10 years, at least what I've learned so far, is that their pharmacometrics group that deal with PK/PD modeling in pediatrics is quite impressive and quite strong. And I don't think that there's a study that goes through their review where they don't actually do the modeling themselves to make sure that pharmaceutical companies and investigators are testing the right dose for kids. So that has changed a lot in the past 10 years.
I'll echo Judith's comments. Wonderful presentations and an important body of work that needs to progress. Now, I'm a simple adult cardiologist and not used to looking at PK/PD data, but like to look at large outcome trial data. So where is the current sentiment and emotions about moving these kind of analyses into the next phase, and that is doing the outcome trials that are necessary to show that if you get the right PK levels, that you're actually improving these kids' outcomes. So maybe for many of us not in your space in pediatrics, where is the field going, and what's your expectations over the next 5 to 10 years, perhaps?
So I will just, and Danny probably has more to say about this, but everything that we present in terms of the PK data and everything that we do in terms of the PK data starts from one principle. We want to match the exposure in adults. And we want to match that exposure because we know that several trials in adults have proved that that exposure is what works. That's what's going to give you a good outcome. But we don't know if that same exposure is needed in kids. We don't know if we need more, if we need less, and obviously it depends about the disease. So that's a very important question because maybe 10, 20 years from now, when we do the efficacy studies, we're going to say, and we collect PK samples at the same time, we're going to say, well, these kids got better on half the exposure than adults, and maybe we're going to have to change the dose again. So that's a very important question. I think that we're in diapers in terms of where we're starting doing, we're starting doing phase 1 PK trials that were done in adults 20, 30 years ago with ampicillin. I mean, that's like, so, and gentamicin and vancomycin, they're done more often because we monitor them. We monitor their levels, so we have a little bit more information there. But, Danny is obviously doing the efficacy trials that we need.
So first of all, I think some of that's going to be driven regulatory-wise. So in areas in which you can extrapolate, the agency and the European Union are going to allow phase 1 and phase 2 trials, they're going to require that, phase 1 and phase 2 trials. And there you're looking at up to about 200 children per therapeutic, which is about 200 more than were required a decade ago. Okay. And then the agency is going to look at areas where you cannot or they don't want to extrapolate. And that's whether or not you can or should extrapolate is a whole other controversial question. They're actually going to require that we do the randomized trials. Then, so our group has been working on the 100 to 200 patient trials, and we've got a couple of those within DCRI right now. And that's basically being cranked through with Catherine Beresny and Jamie Gow, who are both here, and Debbie Blackwell, and kind of moving from one trial to the next. And that, I think are you guys juggling 3 or 4 trials right now? So that, because we're small budgets, small patients, small nimble team. So, and then what we're doing is occasionally saying, I'm not sure we can extrapolate. So we're going to do the blinded randomized trial. So the fluconazole trial that Christy and Debbie and Jamie and Catherine are working on right now is a randomized, powered trial for prevention of invasive candidiasis to see if all this prediction actually, if we're right. And I think that doing the efficacy trial every time, A, is not feasible. B, is probably not in the best interest of public health because there's only so much pushback you're going to want from industry. But that it's a moral imperative to do it periodically when we're saying that we can extrapolate because we want to challenge the assumptions that we can extrapolate. And there's, I don't know what the right balance is there. So if you guys are simple adult cardiologists, then our goal is to be simple pharmacologists because then we'll be the best in the world. They'll all be good. But I think it'll be a bit of a moving target for the next decade as the European Union legislation gets worked out. Yeah. So Judy, the fund training program that we have is 2 years of PhD level coursework, regardless of whether that's epi or biostats or pharmacotherapeutics. Matt is somebody who kind of picked up on that and kind of went down the epi pathway. So during your fellowship, 2 years of rigorous coursework, and then your first year, 2 years on faculty while you're getting your K award. You finish the PhD and you serve for 2 to 3 years in a joint appointment between Duke and FDA, traveling back and forth to DC, and then you complete your K, and then you go sell your soul to industry or bring it all in for Duke or whatever. But so it's 7 or 8 year training program.
Are you going to revive clinical pharmacology for physicians?
That's on my agenda.
Seriously, have you written about your program? Have you written it up?
Well, I mean,
training program. I mean, that's unique.
Yeah, let's do this because we're right at 1 o'clock. We do have a K24 and a T32 in, but we have not put this out into a peer review publication. We should talk offline about that. Okay, thanks you guys.